or to Charity, and we can ask them on your behalf. All right, so first and foremost, Charity, please take us away.
Thanks, Sarah. Thank you, everyone. Good evening. It's good to see you all here, and thank you so much, Dr. Mohandas and Gladys, for joining us this evening. It's a unique opportunity for us as ethnic minority to discuss diabetes and pretty much everyone in UK, because it's one of the fast growing conditions. I won't really touch on two stats because it's your specialist, Dr. Mohandas. I don't want to do a disservice to that. But in UK, there is about 4.9 million people in UK that are affected by diabetes, and probably 13.6 million that might have type 2 diabetes. 850,000 probably are just sitting and not knowing whether they've got diabetes or not. Diabetes itself has got a lot of complications, as you might be aware. For those in the medical field that are here, we've got some microvascular and macrovascular complications, but I won't discuss that. I won't talk about that because I've got the specialist here, and as I say, I don't want to do that a disservice. It's a huge topic on itself, diabetes, and I think we'll have to run a bit of more series, and we might have to invite you back, Dr. Mohandas and Gladys, to come and speak with us, because it touches a lot on mental health, all sorts of complications physically. So it affects our eyes, retinopathy, nephropathy, all sorts. All the systems are affected by diabetes, apart from the, as I've mentioned, psychological impact, economic, and the social impact, and as well as the burden of disease to NHS and the finances. So it is a huge problem. We did see a lot of effect on diabetes during COVID when they were giving steroids and how blood sugars were uncontrolled. And it did affect mostly people with on HIV, on antiretroviral with HIV. So it's something that we need to be discussing. Unfortunately, it does affect us a lot as ethnic minorities. So it's something that we need to really discuss and work on. So over to you, Sarah. Thank you, everyone. I hope you've got your pens and you take notes. I hope you enjoyed the session. Thank you so much.
Thank you very much, Charity. I think for me, I'm very excited because I work in critical care, and diabetes was a big thing during the pandemic. Insulin, blood sugars, all of that was a big thing, a massive side effect of management of COVID. So without further ado, I'd like to introduce our first speaker. This is Gladys Wilson. So Gladys is a diabetes specialist, nurse specialist, and she is working at Darren Valley Hospital in Dartford, Kent. So Gladys, I'll let you introduce yourself and I'll pass on the floor to you.
Can you hear me?
Yes, we can hear you.
Hey, lovely. Right, well, I've been nursing about 30 years. I was always a surgical nurse up until 2008 when I moved across to diabetes. And I've worked in this nicely here. We do a mixture of diabetes, so it's inpatients, it's outpatients, pregnancy, pumps, young adults, transition, newly diagnosed, GP referrals. So it's a mixture of everything, which is really quite nice. And exactly as you said, we've seen a big increase in our workload secondary to COVID, with patients either not being diagnosed with diabetes, getting COVID, coming in, secondary to the illness or secondary to the steroids that we've put patients on. They required insulin mostly, most of the patients, and high doses due to the high dose steroids that they had. So yeah, exactly like you, we've seen a big increase in our workload, and also in relation to pregnancy. I think where people were at home more, not getting the same amount of exercise and comfort eating, the amount of our ladies that got gestational diabetes rocketed as well. And the amount of them that actually needed insulin went up a lot over this last time period. And I'd say it probably still hasn't settled quite yet. Today I was going to cover just the basics of what is diabetes. So did you want it that basic, just to go back to a general overview?
Yes, that will be helpful, because I'm just a bit weary that some people within our audience, so we get a cross section within our audience. I will take this opportunity to ask our audience, please drop in the chat your name, where you're coming from, because we have people from locally here in the UK, but in different towns, and from Malawi as well. And sometimes we get people from other areas all over Europe. And please let us know what your background is, because not everybody has got medical knowledge or understanding. So that might give you a hint in when you're explaining things. Please let us not put our medical hats on and not use acronyms. Let us try and explain everything for the layman to understand.
Okay, I'll share some of the slides. And again, a lot of them are sort of fairly basic. And I'm going to cover sort of diagnosis. I look at sort of signs and symptoms as well. Maybe just mention diabetic ketoacidosis rather than go into it sort of as in management in hospital, might be better maybe, and general signs and symptoms. Okay, grand. I'm just going to share my screen. Hopefully this works as well.
Whilst Gladys is trying to sort out the technical side, welcome to all our participants. There's about 22 of us. I know a lot of people might be trickling in. It's about the time difference, because we tend to have quite a lot of our audiences in from Malawi. So the time difference plays a little bit on, I think, with our audience. So fantastic to see that we have somebody from Lilongwe, Malawi. Yeah, I can't say that. Dayang Luke Hospital. Hello, Joseph. Thank you, Charlotte, for introducing yourself. Charity, it would be fantastic if people knew who you were. I'm going to do the same. Brilliant. How is it going, Gladys?
I think I'm getting there.
Okay, okay. You've got the little share screen button at the bottom.
Yeah.
Have you seen that?
Yeah, I'm just trying. Here we go.
Fantastic.
Yes, here we go. Got it. Right, I'll skip over. Can everybody see that okay?
Okay, I've got a blank screen.
Oh, you not see it?
I can't see anything. It's just a blank screen, a white background.
Yeah. You're not seeing any of the PowerPoint?
No.
It's saying you're viewing Cynthia's screen.
I can see it now. Can you see it now?
No.
You can try. I've enabled content. Screen sharing.
Right, technology. It's all right. It does trip us up sometimes, but it's all learning for all of us. We've all had to learn and develop new skills in COVID. Oh, fantastic. We've got it.
Fantastic, yeah.
We've got it.
Wouldn't
Is
allow
one
me first.
slideshow and from beginning?
Yeah, the first bit's very lots of facts and figures.
So we can go there.
Yeah, we can
Can
carry
you
on.
see?
Yes, we can see that.
Okay, go on.
I won't give you all the facts and figures because it'll probably be just a tad boring. Okay, something very, very basic with regards to sort of diagnosis of diabetes. Let me just see if you can see this a little bit clearer. Not liking my PowerPoint at all.
Well, you've got an interactive diagram that's coming up.
Grad, at least you can see that. But,
Yes.
right, I'm going to come out of this one. I'm going to show you something else.
Okay.
This is the trouble. Right, stop sharing that. So I don't like that one. It doesn't like my PowerPoint with all the things coming in on it. So I'm going to do that animation.
I think the powers that be don't want us to talk about diabetes. So diabetes, it's one of the within Malawi, I know it's considered to be a silent killer, and it is a topic that needs to be discussed because they are cultural issues that are attached to diabetes, especially with type 2 diabetes. So I would like to hear from my fellow healthcare colleagues in Malawi or people from Malawi with regards to their perspective in terms of how they are working with, managing and living with diabetes and what that means for their community.
Keep going. See the slides.
Yes, we can see the slides.
Yes, we can.
And I
Yes,
think
we can.
just go like this. Yeah.
Yeah. Yeah.
Whichever
I'll
you want to
skip
shift.
that
Yeah.
bit.
Yeah. That's fine. Yeah.
Okay. Right. So we'll talk about sort of main types of diabetes. So we've got type 1 diabetes. And again, with that, really what happens is the body attacks the pancreas and the cells that produce insulin. So for these patients, really, their treatment is just insulin. Signs and symptoms of somebody who has diabetes will be things like increasing thirst, feeling tired, drinking lots, possibly getting repeated infections. So sometimes we're finding that people are presenting to their GPs with repeated urine infections or candida or thrush infections. Type 1 diabetes we think of as being more for younger patients, so under 40, but that's not necessarily so. We're finding patients now can develop type 1 diabetes at any age, and even we've had patients in their 90 who've presented with type 1 diabetes. Type 2 diabetes is somewhat different. So, and the treatment options are different. So with type 2 diabetes, patients develop either an insulin resistance, and that can be linked to ethnicity. So again, if we think about type 1 versus type 2 diabetes has got a big genetic link. So Afro-Caribbeans, Indo-Asians, and some of our European countries as well have got a bigger incidence of type 2. So for diagnosis, what we'll be looking at is somebody who's symptomatic, but we'll also be looking at high blood glucose levels. And we do a blood test called a HbA1c that looks at somebody's average blood glucose. We may also diagnose somebody if they have symptoms. So they're feeling thirsty, they're feeling tired, they're passing lots of urine. If they've got symptoms and high blood sugars over 11, then that can be diagnostic as well. There can be other reasons why people get high blood sugars that may just be for short term. So in severe illness, they may develop high blood sugars. And also maybe on some of the medications that we put patients on. So they may get diabetes that is reversible, because once the treatment has been withdrawn, they'll go back to pre-diabetes state. So particularly steroids will be one of the things that would come to mind. Let me just pop onto another slide. Gestational diabetes, and again, quite a big cohort of this, and it's usually diagnosed at 28 weeks gestation or afterwards. These patients will be at high risk of developing diabetes later on in the future, and they may be treated with just diets. So it'll be really limiting carbohydrate portions, And you're looking at things like bread, rice, pasta, potatoes, and that in relation to that. And for some of our patients, it's really a big cut down on with their portion sizes that they'll manage their diabetes. But again, they're a very good cohort of patients, because for them, it's very much about the baby. So they will starve, and even our African ladies that come to us that are used to big portions of rice, suddenly those portions will be nearly non-existent because of the baby. And it increases the risks for them diabetes. So as well as long-term complications of diabetes, there are risks to babies and to mums as well. So there's a few different types. You've got type 1, type 2, gestational diabetes, and there are other subgroups as well. But for the moment, I think just stick with type 1 and type 2. So type 2 patients can be treated with insulin so that they have to inject. They maybe just be looking at their diet and lifestyle and reducing their weight. As soon as we carry extra weight, we need more insulin to manage our blood sugar levels. And normal blood sugar levels really would be between, say, 3.5 and 8 millimoles, which is what we measure glucose levels in. So for patients with diabetes, they will have higher blood sugars than that. And as the ladies were saying, the reason that we want people to have good control of their diabetes is, one, for day-to-day well-being, so that you actually feel well, that you've got energy, that you're making use of the food that you're actually eating. But also in the long term, diabetes can cause lots of irreversible complications. So problems with eyesight and damage to the small vessels in the backs of the eyes, but also to the kidneys and nerves, which have got small vessels attached as well. And here in the UK, we screen our diabetes patients at least once a year for those complications. So they will have screening, and they'll be either looked after by their general practitioner, or they may be under the consultants in hospital as well, for their ongoing reviews. So we'll be looking at their kidney health, we'll be looking at their cholesterol, because again, with diabetes, if your blood sugars are high, the blood is stickier, so patients are more at risk of all the cardiovascular complications. And obviously, if they've got high cholesterol as well, which often goes hand in hand with poor glucose control, then they're much more at risk of heart attacks and strokes. And these are all the things that we're trying to prevent when we're getting patients to control their diabetes generally. Okay, so symptoms, these are some of the things that we might want to look out for, because again, we want the general population to be aware of diabetes, because the actual incidence of diabetes is growing across the world greatly, and it's a big cost. And here in the UK, the cost of diabetes is probably 10% of the whole National Health Service budget. And I would say of that 10%, 90% of that is spent dealing with complications. So not in the treatment of diabetes or trying to prevent diabetes, but actually dealing with the complications of diabetes and potentially possibly poor control. So signs and symptoms that you're looking out for are all of those things that I mentioned earlier. So you may be feeling thirsty, more tired, losing weight, because again, where the body tries to maintain normal glucose levels, it tries to get the kidneys to pass out more glucose through the urine. And that's why patients can be more inclined to get thrush and urine infections. Again, the symptoms will be the same for both, but type 1 diabetes, sometimes it can be much more sudden onset of these symptoms, whereas type 2 patients can have type 2 diabetes maybe for 10 years plus, because we know by the time they've been diagnosed, they've already got complications, and those complications would generally take at least 10 years of poor control to develop. So screening of patients is a big and very important thing, really, to try and prevent people getting to the stage where they've got those severe and long-term complications. And whether that's just looking out and making people aware of what to look out for so they know when to seek help. Risk factors, as you can see, the older we all get, the less good our body is at sort of coping day to day, but also your family history. If you've got other family members with diabetes, you yourself may be more prone. And like we said earlier, Indo-Asians, Afro-Caribbeans, there's a much bigger incidence of diabetes, particularly type 2 diabetes, to look out for. Your other risk factors, don't know if you want to think about these, everybody. Think about your waist size. If you have a little look on the slide, you'll see for ladies above 31.5 inches or 80 centimeters, so you might all want to get your measuring tapes out later on. And for the chaps, over 37 centimeters, over 37 inches, not centimeters. So again, think about your waist size. What size are the trousers that you're wearing? What is the waist size? We're more inclined to get diabetes if we're overweight, if we're less active, and depending on certain drugs that we're taking. And obviously pregnancy for some patients massively increases the amount of insulin that we need in order to control our blood sugars. So that's why that's a big risk factor. And as you can see, some of the other things here that you may want to think about, obviously steroids we've mentioned. If you've already got high blood pressure, high cholesterol, or history of heart attack and stroke, again, some of those things go hand in hand with type 2 diabetes. So if you've got one risk factor, we may want to be looking to see if have you got any of the other risk factors as well. Polycystic ovary disease. So again, for some of our ladies, there is a link to that. And we do look for patients sort of before they've got the diabetes stage. So you can have things like fasting high blood sugars. So when you wake up in the morning, sometimes your body's it's set wrongly, if you like. So those readings may be high in the morning when we do sort of increased testing. If you've had trauma to your pancreas, big link with pancreatitis and excessive drinking as well. So that can cause diabetes, because again, it's the pancreas that's involved in breaking down alcohol, but also it's your pancreas that's involved in maintaining glucose levels. So by producing insulin, but also by producing glucagon, which gets us to release stores of glucose from our liver if we're starving or times when we've not eaten enough calories. It could be trauma, so it can be secondary to maybe surgery or road traffic accidents or that type of thing as well that can cause. And again, there is a big link with depression and diabetes as well, and that may be because of the being able to look after yourself if you're not mentally in that right frame of mind. It may be some of the drugs that we put patients on as well. Some of the antidepressants can actually have a big impact on how much insulin our bodies require to maintain normal glucose levels. Our antipsychotic drugs particularly, you may find somebody develops diabetes because of the medication that they've been started on for other treatments. Diagnosis. So if you're thinking about diagnosis, this is sort of what we'll use here. Again, you may have different parameters. You may work with sort of the WHO guidelines. So they will be pretty much along these. So if we do just a finger prick check, so if somebody does a finger prick check on your blood, if that's more than 11.1 and you're symptomatic, we'll consider that a diagnosis. If we do blood tests, we may do a fasting blood test, and if that's over 7, that can be part of the diagnosis. We may look at your response to food as well. So we do what's called an oral glucose tolerance test, and this is what our pregnant ladies have to suffer. But with that as well, we'll look at your response to that carbohydrate or that sugar load that we give you. And if that 2-hour test is more than 11.1, that's diagnostic for diabetes as well. There's another test that we do that looks at how much sugar is attached to your red blood cells. So it's slightly different from the information you're getting when you're just checking your blood glucose on a finger prick check. But if your HbA1c is greater than 6.5% or 48 millimole per mole, that's diagnostic. If it's sort of normal day to day and there's no big history of severe illness recently, and no sort of history that we've put you on steroids just before this diagnosis. And again, looking at the diagnosis, so 2 elevated results on different dates. That's the other thing as well. So you're looking to see that that wasn't just a one-off high reading or an abnormal test. Okay, and this is just talking about, again, these are sort of what we call pre-diabetes. So somebody hasn't got a full diabetes diagnosis, but there is an issue with their overall glucose regulation. And for these patients as well, it may be things like looking at their lifestyle that will stop them actually going on to develop diabetes at a later date. And this is the kind of message that we like to get out to patients here, or people here, trying to prevent diabetes in the first place, particularly type 2, that you can prevent by just lifestyle measures alone. And this is, again, looking at that response to fasting, but also fast to food. This is what we try and get our patients to achieve when we're looking at overall diabetes control. So these are some of the things that we will measure when patients come into clinic, or that your GPs may be doing for you when you're looking. And the reason that we're looking at cholesterol and blood pressure is because of that big risk of heart attacks and strokes that can be associated with your diabetes if your control's not good. But the other thing I usually try and get through to our patients as well, complications are there, they're a big risk, but if your control is good, you need never get complications necessarily. And we've got patients that have had diabetes 50, 60 years that do not have complications linked to their diabetes. So it's not the be all and end all that if you get diabetes, you're going to get all these other complications. This is what we call sort of perfect control. That is not easy to achieve. So fasting levels between 5 and 7 when you're checking your glucose. If you were checking 2 hours after your meals, really we don't want to see a glucose more than 10 millimoles, which is what the glucose levels are measured. And we'd say if you're measuring blood sugars across the day, bedtime will often say we're happy for patients to have slightly higher blood sugars, so that allows that blood glucose level to drop through the night when they're not eating or drinking anything. HbA1c, so we still talk in percentage, which is very old-fashioned. We shouldn't do it. Most places will be talking in millimole per mole, and that's probably how most of the world talks now. 6.5 is really old-fashioned, and we shouldn't really be using it. And that's really it for that simple part of just thinking about the very basics of diabetes. There's a nice little video that I can try and share with you. I mean, I'm not sure how much time we have. It's about, I think, 10 minutes, which may be too long. I'll let you maybe go to Dr. Mohandas and see if she's got anything, and then we can always go back to the little video afterwards if we have time.
Yes, that will be fantastic, Gladys. Yeah. I think we should let Dr. Mohandas get a chance to speak. And then if we do have time, we'll see if we can squeeze in that video. Is that all right?
Questions as well, because, yeah.
Okay.
And stop sharing.
Okay. Thank you so much for that, Gladys. I know that was like a whistle stop, but you've covered so many different topics. And I think people have started to trickle in some questions, which we will pick up on a bit later on. So whilst Gladys is trying to come off the screen, I'm just going to introduce our next speaker. So our next speaker is Dr. Cynthia Mohandas. So Dr. Mohandas actually started as a consultant in December 2016 to improve and transform the delivery of diabetes services in Dartford and to provide effective clinical leadership to develop a short-term and long-term strategy for expanding and redesigning diabetes services. She has completed extensive specialist training and has been studying in diabetes research for 3 years, looking at the pathophysiology in the development of type 2 diabetes in Black ethnicity, which was a Diabetes UK funded grant in the Centre of Excellence in Diabetes Care, King's College Hospital in London. So Dr. Mohandas's vision is to develop a diabetes center of excellence locally, taking the mentorship program developed on other projects as well as guidance from other successful models of care to improve inpatient and foot services, develop better links with the wider local community, taking into account the vanguard development and also wider London community, in particular relationships with teaching centers. So I got that off Diabetes UK, Dr. Mohandas. If you're wondering why I'm rattling all that off. So Dr. Cynthia Mohandas is actually a consultant in diabetes and endocrinology at Darrant Valley Hospital. So I'll leave the floor to you.
Can you see my first slide, guys, all of you?
Yes, we can.
Yeah, oh, you can see me and my slide, yeah?
Yes, we can see you.
Okay, fine. Let me try to move this. Can you see it now?
Yes, we can see it full screen.
Perfect. So let's try and move this out of the way. And yes, so Sala, thank you so much for a wonderful introduction. So when she kind of invited me to speak, you know, I was really thrilled because my heart is in diabetes, and especially in Black African diabetes, because when I was training in King's, I got to meet one of the world famous Professor Emil. And, you know, in her career, she always did research in type 1 diabetes. And that is mostly for, you know, as you know, type 1 is most common in UK population. But I think at the, you know, in her later years, she was quite thrilled to do something for the local population in King's. And you know that 40% of population around King's, which is, you know, those of you who come from Southeast London would know have diabetes. You know, they consist of Black West African and also other African communities. Yeah. So basically what we did was we took 20 Black West African men and 20, you know, white European men, because we know that in women from Black ethnicity, it's mostly obesity driven, but in men, you know, we never know what is causing diabetes. Yeah. So that was my first kind of introduction to that. And I really enjoyed working with the community, because Diabetes UK said that you cannot engage the community. But all my participants, you know, came for, I think for the first time, those, you know, tests were probably, you know, people who work in research would know that it's how hard, you know, to stay whole day. So I brought them for 4 whole days, and they were so dedicated because they wanted to contribute to the community and to have more information about diabetes. Yeah. So finally, what we found was, unfortunately, you know, in Black community as well as in Asian community, genetically, we all know that we are predestined. And then we also have food, which is very, very, very carb dense. And if you ask me to give a prize, I will still cry being a diabetologist. You know, although we, you know, in healthcare, we try and cut down, it is very, very difficult to give that, you know, the carb, especially in the evening. You know, whole day we try and work around eating nothing, but then in the evening we have that meal, and that is your killer, because then at night, you know, you go with very high sugars at night, and that, you know, what happens is it goes and deposits as lipids, you know, because the sugars are converted into fat. And that is why we end up with, you know, early heart disease, strokes. So this talk will be, I know there's a variety of participants and mainly nurses I can see, but also some lay people. So although my slides would have slightly complex information, I'll try and make it as basic as possible. Yeah. So going to the next slide. Oh, it's not moving. Ah, finally it's moving. Can you see that? Good. So I know we don't believe in all this, you know, I'm sure many of us come from kind of Christianity or other religions. We don't believe we all come from monkeys, but still, you know, it's just a funny slide to say that, you know, our ancestors, you know, did a lot more physical work. Yeah. So they did physical work. And, when they were hunters in the forest, they got food only, at certain points. When they were hungry, they got food. They didn't get, like food like us, 3 meals. And then they weren't sitting in front of the computers or, sitting and doing clinics all day, eating nothing. And, so at that time, probably there wasn't this, much of type 2 diabetes. Whereas you see, lower down, our lifestyle has got more sedentary and our food has got so calorie rich. And there was a very famous professor, from Asia, and in his talk, he said that both African as well as Asian ethnicity can survive starvation much better than food. So he said, actually, food is killing us than, like we can survive starvation, we will live through starvation, but food is actually, giving us all this complication and it's killing us. So that was really an eye-opener. And I think Charity has nicely put already the data, but just to remind, it's a huge burden. Yeah, 3.9 million people have diabetes, and 10%, which is 10 billion of NHS budget is spent on diabetes, and 80% is actually spent on treating potentially avoidable complications. 15 to 20% of acute trust bed, which is 1 in 5 beds, is occupied by diabetes patients. So, it is a huge burden for NHS. And that is why, the acute trust really, want to improve things. And also in the community, it's a huge burden. How much ever money is poured in, it's kind of, it's not enough looking at, the complications. So until drastically, we all take up, individual responsibility to cut down what we eat and exercise more. I know it is easier said than done. It is going to be a big problem. So, a handful of diabetologists or DSN, as you know, Gladys really didn't give much, introduction to herself. So Gladys has been single-handedly managing the whole of diabetes of Dartford, I would say, because, of course, we are consultants, but there used to be so many insulin starts, inpatient diabetes, and what's the other thing, pregnancy, all those kind of things, she mentioned that most of the time, there's only 1 or 2 nurses in the shop floor to manage all this. There's not enough funding. Luckily, now we've got a lot more, a couple of new nurses, but still, it's not enough. That is because the problem is huge. We have 13,000 people. There's no funding for our CCG. So this meeting is really good for all of you to kind of upskill yourself. And when I became a Diabetes UK champion, they said, you are like this little seed sown everywhere. So this knowledge, what you have, you're going to take it and spread it to wherever you are. I mean, you could be a lay person, you could be a nurse, you could be a doctor, you could be, doing different other things, nothing to do with healthcare. But still, it is a huge public health problem. And we all have individual responsibility to make sure that we live healthy and have a happy life. Yeah. So I know this is quite a complex picture, but I would like to simplify it. Can you see that, pancreas, yeah, the leaf-like organ. So the pancreas is which secretes insulin. And we all, as Gladys beautifully said, we all need insulin to bring our sugars down. But unfortunately, what happens in diabetes, and I would like to point to Black and Asian because, we are the BAMI population, is that the cells, which is the beta cells, which make these insulin, they die quite rapidly once the diabetes, develops. So what happens is we eat so much that we challenge the pancreas that, he secretes and secretes. And then finally he says, enough is enough, I'm giving up, So that is what we are doing when we, kind of load ourselves with that chicken curry or pulao rice or chapatis or, jollof rice or whatever, name it. And, we challenge our pancreas at that time of the night where, he really wants to rest. And then, we kind of just tire him out. That is why you see in Black people and Asian people, they progress quite quickly if we don't have a strict control over what we eat or we have to burn it. Either we eat less or we need to burn it. That's what it says, so a simple way to say that will be like the bathtub, isn't it? So as far as, you open kind of, the hole is open at the end, the water will kind of go through that. But when that is closed, so that is called the insulin resistance. Then, the water overflows and then it kind of, just floods your bathroom. So the same thing, even our fat reserves, we challenge it so much that all the fat pools in our body is overfilled, and then it goes and deposits in your liver, in your pancreas. And in the study which we found that that is what is dangerous. Black men actually are not as obese as the Black women, but they have a lot of fat in the pancreas as well as in the liver, which is quite dangerous. So that is the organ fat. And that also kind of leads to high glucose being produced by the liver. And then we have a hormone in our body called incretin. So when we eat, we feel happy and full, isn't it? But in some of us, we never satisfied. And if you ask some of the pre-diabetes patients, they'll say, oh God, I have a craving, I really cannot stop. So that craving, is the incretin hormone, and all the other gut hormones as well. They play a big role, so which makes us eat and eat and eat. And the interesting research is in the brain, actually. So, they did in King's research on brain of people who are insulin resistant and insulin sensitive. The slim ones, not all slim ones are insulin sensitive, but generally they are. And, the insulin resistant or the obese ones from BAMI population, and also, even the white population. So what they actually found is that people who are insulin sensitive always go for the low calorie choices. Those are the ones who love the leaves. One of my colleagues calls it as a rabbit food, so they just generally love, salad. So when pictures of such a food was thrown in front of their eyes, they get excited. Whereas, people who are insulin resistant, they just didn't score that high at all. When they saw ice cream or a nice bowl of, rice, or, whatever, chocolates, name it, their levels, they scored very high. And those centers of the brain, which we call it as hedonic centers, like the same centers as addiction, actually light it up. So that is very interesting because, food, we say sometimes is addiction for people. And sometimes our brains are pre-programmed, which means the insulin resistant people need twice as much as willpower than the insulin sensitive, because some are already pre-programmed to love those food, isn't it? So I think that is where a lot of emphasis goes into the lifestyle. One is the insulin resistance. We are genetically programmed. And then coming down, so that is insulin resistance in the fat in your muscle, and also, the kidney actually, the glucose excretion decreases and there's more glucose in the blood. So that is kind of the mechanism happening there. So then what happened is, in UK, we are still doing the guidelines. If most of you, the nurses, would know that the NICE guidelines are always updated because, they have to sit as a panel and to agree. And, with NHS, costings play a big factor. Whereas in America and the rest of the Europe, they are far ahead. They want to go for the best drugs, or they want to kind of take the latest research. And all the UK practicing diabetologists or DSNs, now almost we have moved on to that, although the NICE guidelines is still about 6 years outdated. So this is the guidelines, and Gladys rightly pointed out this. Although I wouldn't bore you with this, I wanted to point out that people with type 2 diabetes are at risk of heart failure, which is 33% more than the general population, stroke, and that's 72%. And if you actually look into the BAMI population, the risk of stroke is very higher compared to the white population, and MI 54%. And the microvascular, which is your kidneys, your little nerves in the feet and hands, your eyes, all that is more than 50%. And Gladys said, I shouldn't be scaring you, but I would like to scare you, because having worked in King's, I do see, some of them, of course, we always have people, isn't it, who take things very seriously, and we do have people who are just chilled. So this is not for people who are already, serious, doing everything strict. But for those of us who are chilled and laid back, and especially sedentary post-COVID, because we see at least a 6 kilogram, which is 1 stone weight gain in people who have type 2 post-COVID in some of the studies. So for that reason, I'm going to scare you to, I show this slide to people who say, doctor, just leave me alone. I'll be fine. The sugar is not going to affect me. So this is for those people, who are kind of have that relaxed mindset, who love food, not for the ones, who are already scared. So those people, when you look at this slide, and you have to, as nurses as well, you can show, if you Google, all these kind of data comes up. So you have to kind of say what those sugars do to you, because, it's not the high sugars, which, on a day-to-day basis, which people are worried about, because, of course, once the symptoms of high sugars, which Gladys mentioned, resolves, then you are like, oh, I have diabetes. Oh, I don't have, some of them are in denial. But when you know that a disease can cause all these problems, and I tell my patients, some of them tell me, doctor, I want to die. I don't want to live anymore. This COVID has come. But I tell them, we will not, let you die, because we'll give you enough tablets. But just imagine going to the hospital with a heart attack or stroke, or being on a dialysis, or, having your eyes blind. Would you really like that? Because, sometimes people say, oh, nobody told me that. I'm sure all of you nurses tell them. And this is kind of, knowledge to everybody who are educated, but people are in denial. So I would say, to those people, just kind of say, it's not about dying, because, of course, there's lots of medications, and we have hospital, good nurses, doctors, GPs, but, it's the comorbidities, it's the quality of life and the number of medication you're on. All of you who work in healthcare, once you kind of have a label, you end up on 4 or 5 medication. Once the heart people come in, they add 4 or 5 medication. Then the kidney people add 4 or 5. Then in a dosage box today, when I see ill patients in MAU, I see them like 20 patients, 20 or more medication, and my junior doctors more, writing them down. So we think, how can, even if you're worried about writing them down, I wonder, are you really taking? And you do know that, people who have all these conditions, the compliance is poor. We can touch our hearts and say, how many of us as healthcare have ever, finished a course of antibiotic at the right time properly? So then, when we ask our patients, and when they, of course, like good students, they want to say, yeah, I've done it. We almost know that, it's probably happening, like say 50 to 70% of the time, but not all the time. Yeah, that is human. And of course, say if you're in a care home or you have dosage box and someone gives it to you observed, that's a different thing. Yeah. But a majority of us, before we go to that stage, that's what happens. Now, going to what's happening and how to kind of manage this disease. Yeah. So in the last 2 years, I said there's a lot of, information generated. So before, the drugs, you probably, all of you know metformin and glycoside. Those are like old for 60, 70 years. When those drugs came to the market, people, the pharmacy or the pharmacology company which produced it, they didn't need to give any robust kind of trial evidence about heart or stroke or about mortality. But now all, the drugs, the new drugs which have come to the market, you probably know all the drugs which you cannot spell, which is the gliflozins. Yeah, it's called SGLT2 inhibitor. So all those drugs, dapagliflozin or empagliflozin, whatever, ends with the flozin, edagliflozin, all those drugs, canagliflozin, and also, you probably would have heard about the injection which helps you lose weight, GLP-1 analog, which is, works on the incretin hormone, which I mentioned. So it helps you lose weight, it makes you feel full, and also, of course, it improves your diabetes. Now, these drugs had to go through a very rigorous trial and had to show that they have cardiovascular benefit. So now, we have we can challenge the drug companies because there's good competition, and then to say, what drugs work and what drugs do not work. So there's, as I said, before it was all, if you go to a GP or a doctor, he'll give you a tablet and say, go off, come in 6 months. Now, you probably know about the big trial, which came in all television. It's called the direct trial. So the first time there was this big professor, Roy Taylor from Newcastle, he did a trial to show that strict lifestyle, controlling the food you eat can really lead to remission in type 2. All of you would ask, can it be cured? You probably want a pill to cure it, but the only way this professor showed it could be cured is by having a low carbohydrate diet, almost fasting away. So, but in that trial, people, of course, because they were in a trial and they were like really strict with those things, there was, a huge proportion, a huge proportion. The 2-year data actually showed that people who had lost about 2 stones, a significant amount of their body weight really, led to a remission. But what happens in 5-year data, you see all those people who lost that weight, who couldn't control, they all kind of relapsed. And that is what happens with most of the lifestyle studies. So that is why I tell you guys, and all my patients as well, don't go for any crash diet or come on, like the very strict, because initially you'll be beautiful, you would, it'd be so motivated, but even after 6 months, when you kind of relapse, is because you just it's a rebound phenomena, isn't it? So always go for something lifestyle which is kind of bite-sized. So that's what I speak to my patients. When I consult my patients, I say, okay, tell me one thing which you're going to give up, and then we have a discussion and we have like an agreed care plan. So that is the great emphasis on lifestyle. And then before, it is like you go to a doctor, like a headmaster, and then the patients are so scared. You just like, doctor, whatever you say, we will accept, and they go. That was the older generation. Now, they question you. So there's this greater focus on patient-related issues and self-management. And then, as I mentioned already, we have evidence from all these cardiology trials, and they have to show, these drugs have to show that they reduce, heart attack, they have to reduce stroke, they have to reduce hospitalization due to heart failure. Now, this is a nice one for all of you, who work in patients with type 2, or all of you, in your family. You could be a patient yourself. So as a diabetologist, I love using this, and it's something nice to remember. So we just open each box as it goes. So what you assess in patient, because, a patient is, each person, as you know, is different, isn't it? So one could be a teacher, one could be a taxi driver, one could be driving buses, one could be a high-flying professional, one could be, doing a lot of physical activity, and other person probably just sits in 24/7. So the lifestyle is very, very important. And then you find out whether they've got kidney disease, they've got heart. AS means atherosclerotic cardiovascular disease, and CKD you all know is chronic kidney disease, and then HF is nothing but heart failure. Yeah, so we see, is it the heart, the kidney, do they have heart failure? Then age, of course, that really matters, because now even 17 to 18-year-old in BAMI ethnicity develop type 2. We have young people. Before, that was only type 1, but now my colleague who does young adult clinic, he tells me that we have so many young people, which is really sad because of all the food and the poor lifestyle, our current generation is going through, playing games all the time. We have such young people with type 2 as well. And then, so age is important, HbA1c, weight, and issues such as motivation and depression. So there's, as Gladys already mentioned, there's a lot of underlying depression. Yeah. So if you find, one of the studies which I did in King was with a psychiatrist consultant, and that study was to see what proportion of people had depression and worsening type 2. So there's underlying 2%, they say, but in some population it could be as high as 10 to 20%. It depends on your area, your socioeconomic status, and also with post-COVID you find so many people are depressed because they are jobless, they've been locked up. At least we as professionals, we've been working, we've been having having some routine. And I really, sometimes we think when we are working, oh, those people are so lucky sitting at home, but it isn't, because when you have nothing else to do, an idle mind is devil's workshop. So then you eat and then you put on weight and then you look at the news and get more stressed. So your cortisol goes up. And then, that actually there's a huge proportion of type 2 diabetes, as you guys rightly pointed out, post-COVID, and COVID itself is causing diabetes. Then of course, on the top of that, we've given steroids to so many people, and that has caused worsening of, type 2 diabetes. Yeah. Now going to the next picture is, as Gladys said, individual target. The HbA1c is the amount of sugar which is sticking to your red blood cell. So as she said, the old unit is a percentage. UK, we always like, people who are the older generation, they still like it. So for patients, they still like the percentage, although, internationally, we've all gone to millimole. So 6.5, yeah, or 48 is kind of the golden number. Yeah. So after that, it is just bad. And but not all of us can reach that perfection. So when you see patients, say, if they have in your new unit, say 48, that's fine. But say if they are, say 90, yeah, for the sake of argument. So you can't expect someone with 90 to come down to 46 in 3 or 4 months or even 6 months. So you just tell them what lifestyle you're going to change. Say, if you've never moved out of the house, at least start kind of walk gently, the recommendation I'd come to in the next slide. So you make sure that they do something, and then you set a target, because, some of the personalities are deadline personalities. If you really give them clear instructions, they will follow. Actually, it's like prescription. And you also kind of assess, if you're starting any tablets, you kind of choose things, how it will impact the weight. And say if someone is driving children to school in a school bus, whether it causes hypoglycemia, do they know how to measure their sugars? And then we have to have a discussion with the patient even about the side effect profile. As I told you, these new drugs, which you can't spell, the gliflozins, the SGLT2, they make you wee a lot. It works by kind of excreting your glucose and water in the urine. So you have to tell them, people who are driving, they can't be just running to the toilet. Long distance drivers like lorry drivers, they find it very hard. And in women, it causes urinary infection. So, you have to be clear and give them clear, tell them what to do. Otherwise, they give up the medication, which is really good for them in a day or two. And then complexity. So with tablets, usually people like it, but say, the complex insulin regimen, say if you have to give insulin twice a day, even that is difficult for some people. Sometimes, as you know, you have to give injections 4 to 5 times a day. So, and also how you give it, which is usually, now pen. But Gladys probably touched on the type 1, where you give a pump device. I'll show you the pictures of that. So all those things has to be discussed to the patient, and then choose the regimen which they will adhere to. So when say if you have an 80-year-old in front of you, you cannot, who's just struggling with his dexterity and skills, I cannot be foolish enough to say you're going to inject tomorrow onwards for injection. And some people have learning difficulties. So it's the whole person we see. So although you might want a perfect control, you go little by little, are they able to inject? So, Gladys and other nurses, who are with us, they assess if the person is able to inject. If they have a pen, are they able to inject? And then are they able to monitor? So that's important. Then because we all work for NHS, the cost, the availability, and the access, because your reps will come and say, this new drug is coming. But then if you look at the price, your CCG is not going to, let you prescribe, although it is good. I mean, I will fight for my patients if that is what they need. But still, if there are better medications, that's what you are allowed, and your hands are tied sometimes. I like to give gadgets to all my patients, but Gladys will tell you how hard it is to get funding for some of the gadgets for type 1 people, the pumps and the sensors, which we will discuss in a minute. So what then I do is shared decision. So, if you see patients in clinic, they come with their family. Some of them don't know how to cook. Some of them, live on takeaway. So all that information gathering is so important. Are they educated? As you said, are they able to understand? I can't be rattling away and then, finishing my consultation. So I speak for some time, half an hour, and then a new patient, my nurses give about an hour or 2 hour education, if they find it difficult. Yeah. And then you see patient preferences, and an effective consultation includes motivation. If you kind of go through the old school of saying, this is what you do, this is what, if you don't do, you will kind of die. That is very tough on the patient. So, just like empathy is very important, you just judge the person in front of you. As I said, carrots and sticks, isn't it? Some of them, a gentle approach. Some of them, you'd have to be firm. So when you're having the conversation, the personality comes through. So you individualize the patient than just following a protocol. And that's how you win patients. And I find that clinicians who have excellent people skills are very good diabetologists and diabetes specialist nurses, and patients will love them as well, rather than just being dictators, kind of dictating the treatment to them. And I, believe in empowering the patients. I come from King's, and, Prof has put that thought deep in me, is to empower your patient. You don't say, I don't like patients coming and saying, oh, doctor, you know all my tablets, it's there in your system. I say, no, I do not know anything. Tell me what you're taking. And I always find out, where they are in the level of knowledge. And I try and kind of impart bite-sized knowledge to empower them to manage the condition. Because, you have only the 10-15 minutes. But the patient has to manage it 24/7 until they see you in 4 to 6 months time. Sometimes our waiting lists are so huge, isn't it? So in that case, we have to be so careful about what information we pass to the patient, isn't it? And also it is important to empower them and not kind of keep knowledge from them and they feeling, oh, the doctor knows everything, I don't need to worry about anything. Yeah. And then you have to ensure access to DSMES, means diabetes, self-management, and education and support. Although it sounds kind of posh, all it means is just making sure they understand the disease and they're able to manage the disease, and they are able to, understand the impact of whatever the behavior. If they are just feasting on cakes and Coke, they might be in denial, but at least you should have passed the information how that kind of behavior is going to affect them in the long run. Yeah. And then agreeing a management plan is very important, and implementing the managing plan, and then ongoing support, that is very, very important. And then always we kind of review and then assess the management plan. Yeah. Good. Let's go to the next slide. Encouraging lifestyle and diet, I can't emphasize enough, and all of you kind of know what it is all about. You see the good and the bad. So healthy diet and lifestyle is the cornerstone and of success for effective management of type 2. So according to NICE, diet and lifestyle advice should be enforced at each consultation. So, it's not that one time, because my patients, who saw me after COVID, they were like, oh, we missed you so much because we lost the motivation. Because we know that we are going to see Dr. Mohandas, that week we just get ready with everything. So it's like, all of us have that behavior, isn't it? If you're going to meet someone, we just take that extra effort. So they do enjoy having those consultations, some of them, although they do know what to do. So that's why, we have a lot of telephone clinic with nurses, just to kind of keep the motivation and keep them upbeat and reminding them in a nice way that relationship with the doctor patient, which is kind of, although, it's old school, it's so important, even with all the gadgets, so now we have telephone clinics, we have, some patients that have teleclinics. And so that's very important, even in COVID or post-COVID or how many ever waves, I hope we don't, but, come, it is important to have that patient contact. So it is out of all the diabetes centers in Kent, there were many places which were closed, but we consultants as well as nurses worked all through the COVID. So morning we will be in the wards, afternoon all of us were speaking to the patients, over telephone, and any patient who needed to come in urgently, we kind of took action on that. Yeah. So now going to the next slide, we'll skip a slide. So with exercise, yeah. So the NHS recommends 150 minutes of moderate intensity, which what is moderate intensity is running, walking, jogging, anything, you know, to keep you moving. Because most of my patients, as soon as you talk about exercise, they go, oh, I've got knee pain, I've got ankle pain. And I say them, even if you're sitting, just keep yourself moving. You know, even if you cannot, just, you know, keep yourself moving. And then when they moan, oh no, I cannot move this joint, I cannot move that joint, then I say, then you don't need that many calories. And then we come into some agreement that either they do something before they see me or they cut down something. Yeah, because otherwise, whatever medication you're going to pour in, you are just going to add on and on and on to the burden and never really lead to their well-being, isn't it? Because we all know as healthcare professionals, the tablets, which all I'm going to tell you is going to come with side effects. So people with type 2 typically do not meet this recommended amount of exercise. We know that. And one approach is to improving participation and to provide a prescription. So actually, you know, exercise is actually the best prescription you can give anybody. And you would see now there's loads of activity going on. And, you know, to be honest with you, I find that my type 1 patients, the slim ones who are always, you know, active, they do more. So, you know, they go for 30 kilometers bike ride, whereas my type 2 patients, whom I always want them to move, you know, they go into their sedentary. So that's why we say this is a disease of the mind or the brain. So and then my type 1s will be coming with hypos. I want them to rest a bit, but then so I just wanted to reverse, you know, if I could transplant the brains over, that is what I would really want to do, but we cannot. So it's just, we need to kind of give that information again and again, and you know, not kind of let them lead a life, because, you know, we are responsible. Of course, it is individual responsibility, but then we need to help them, isn't it? Because if something happens and when they come in with complication, you know, my heart really goes out, because every patient I cared for when they came in with COVID, you know, Gladys and I and the rest of the team, we'd be so worried to see, you know, what's happening. And so the next is the first line treatment. Let's go through that. I think 7:30 already. So we will just go through the basic treatment. Yeah. So metformin, you all know, is the first and the golden treatment. It's been there for a long time. And now, as I said, it's because, you know, there's a lot of complex algorithm, but I will just go through the basic. If you have heart disease or if you have heart failure, then you go through this drug, yeah, which is a new drug, which is the GLP-1 analog, because it has got, you know, good heart benefits, or the SGLT2, which I told you about, all the gliflosins, which makes you wee out your sugar. So that is really good if you have heart or kidney disease, amongst the newer drug after metformin. And if you want to minimize hypoglycemia, say, you know, you don't want, well, nobody likes hypoglycemia. So in elderly people, we use something called DPP-4, which is, again, you know, you must have heard about sitagliptin, linagliptin. So all the gliptins come under that. And again, you know, all your GLP-1, which is your liraglutide, exenatide. So all those injections, which used to be daily or twice daily before, now it's only once a week. So that's really good news for people to lose weight. And we use quite a lot because, you know, this drug makes you feel full, makes you eat less. Of course, it gives you side effect of nausea and vomiting, but that is only for a short period. And these drugs have clearly shown to have cardiovascular benefit. Yeah. And if you need to minimize weight gain, again, the same two drugs. So you would find after metformin, most of our diabetes patients now, you know, are tried on the newer drugs, yeah, which is all the GLP-1 analog, we call it, or, you know, all the newer drugs. Before they came as injection, and now even tablets are starting to come around. It's called Rybelsus. And then also, you know, with the SGLT2, it's now cardiologist and renal physicians, so which is kidney doctors, now prescribe it independent. Even if you don't have diabetes, they are prescribing. I think diabetologists were the first to get those drugs, the SGLT2, because it makes you even lose water. So, you don't have a heart, if you have heart failure, it is a good drug to have. And if your kidney is getting worse, even if you don't have diabetes, say if you have hypertension or something, they are using these drugs. So that is kind of, the new drugs. Of course, cost is a major issue. So if you work in GP land, you still use sulfonylurea, but we as hospital doctors don't like that much because it makes you put on weight. What this sulfonylurea does is, whether you eat or not, early in diabetes, it secretes insulin. So, I told you, remember, if you secrete too much insulin, then your pancreas will tire out soon, and then you will end up on insulin. So I have a big concern, even during my training days, we found that people, especially Black and Black West Africans, and, as well as, the Asian minority, sulfonylureas, initially it's good and it's very effective in bringing down sugar and it's cheap, but you might end up on insulin soon. So just have to be careful with that. Yeah. And so although it looks very, very big, I have tried to make it bite size. And I said with injection, it's GLP-1 and insulin, which is recommended. I will not go through these. Let's go into insulin. So this is just a kind of a brief overview. So, all of us, as we are, our blood sugars go high when we eat. And then even if we don't eat, as we are listening to the presentation, to maintain the blood sugars in the body, we secrete some basal background insulin. And that is what, we are trying to kind of create. There's human insulin, there's animal insulin, and then there's human analog insulin. Yeah, just for you to know. Now, animal insulins are not used anymore, which is like the pig and the cows. Certain communities don't have that. Most of the insulins we find is normal human insulin, which is genetically engineered, or the analogs, which is kind of the artificial ones which are made. Yeah. And so you have rapid acting, you have short acting, your medium or long acting, and mixed insulin or long acting insulins. And this is just, again, a brief overview. I don't want to load you with information. So you would find that if you're working in the wards, especially with COVID and stuff, you are using a short acting insulin if your sugars need to be brought down with mealtime, because they will start to act novorapid, or will start to act within 15 minutes. And then, it lasts for about 2 to 5 hours. Yeah, you can see that peak if you just look at that. So in all your insulin pumps and stuff, Actrapid is used because it doesn't clog the pump. Humulin S is used in pregnancy as well. So these are the fast acting. They act within 30 minutes. And then, although it lasts for 2 to 4 hours, in some people, it can hang around for about 8 hours. So that's why you see a slightly higher peak. And then your intermediate is your insulatard. Yeah. So that's why the doctors have to prescribe correctly every 12 hours. And you can see that peak. Even with the insulatard, Humulin I and Insuman, you must have heard, there is a peak. So if, these elderly people are not eating or drinking, you should be careful about them, although it is a very good insulin. So that's why, you have the analog. So that is like a plateau. Can you see the plateau? It's 18 to 24 hours, these long-acting insulin. And then in type 2, most of you must have heard about mixed insulin. Yeah. So that's Novamix 30. I know it's very hard to remember these names. So we have, in our hospital, have insulin safety cards, and all your hospitals, if you go through, have a bit of information about this. And if you're keen to learn more about this, there's Cambridge CDEP. Yeah, so that is a nice education program. You can go and do as much as you want, bite-sized learning, or as little as you want. And the newer insulin are the high strength insulin. So, some of my patients ask, what is this 200? So the strength is quite high. So you have to be careful when you prescribe, or even as nurses, you're doing locum shifts. Be careful what the doctor has prescribed, and always check with the patient when it says Humalog 200, because you're giving double strength. The patient can die of a hypo, as not as common, but it's always good to check what insulin you're giving. And the knowledge of insulin is so good. If you're not sure about it, especially when it says 200 or very high amounts prescribed by the doctor, always question that. I tell all my nurses about that. because the onset is very quick and it goes to a peak. The only good thing with this, in case if there's an accident, we have to identify it quite quickly so that you can correct it, because the duration of action is about 4 to 5 hours and can be immediately given before after meal. So you might ask, why do we have to give 200 strength, double strength? Is some people are so insulin resistant, their BMI is so high, the body weight is so high. So whatever you pour in, their sugars, never come down, and they are with steroids, they are very insulin resistant. So that is why we use this, but still you have to be careful, depends if you're not eating or drinking, or, if you're going for operation, you have to be very careful with these insulins. Yeah. And Toujeo 300, similar. This is just, I'm telling you names, whenever it says 200 or 300, be very, very careful, because their strength is quite high. And also with this, they can last with a long acting insulin. That was a short acting Humalog. This, lasts for about 36 hours. So you need to be careful, about what insulin. So always check when it says, 200 or 300. So that's important. And you would find some people are on once a day, some people on twice a day. So that depends, we diabetologists or DSNs, diabetes specialist nurses, choose that. And this is, you must have heard type 1. Those of you who have type 1, you know about the insulin to carb ratio. So this is like for every unit of insulin, so you calculate for 10 grams of carb. So you need to, so those patients need to have some basic mathematics, or, all iPhones have apps. It's called Carbs and Cals. So they can calculate it for you, even, if you're struggling with your maths. Say, for example, if you're eating, you're looking at a pack and that contains 70 grams of carb, you give yourself just 7 units. So that is what we call it as 1:1. So it's 1 unit of insulin for 10 grams of carb. So, our patients get a lot of information about that, because, confusion in this area can lead to a lot of errors. So our dietitians as well, have a lot of knowledge about, insulin and carb counting. And this is mainly for people with type 1 diabetes. Yeah. And then there's information about corrective dose, because most of the patients, that sometimes you've done the damage, you've eaten the cake, and then your sugars go to 22. What do? So usually 1 unit of insulin will bring your sugars down by 3, if you're slightly slim, then by 2 if you're very big. And sometimes for, that 1, sometimes it'll be only 1. So, sometimes, as nurses as well, you'll be giving this supplemental insulin PRN, you'll be giving 6, 6, 6, and then never the sugars come down. But you have to be careful that, the frequency is important, that 4 hourly, because what can happen is you keep giving quite a lot of insulin, then they stack up and then they will end up with a hypo. Yeah, that's very important. So we do know that hospitals are the dangerous place where sometimes very competent patients are not allowed to manage. So if your patient is competent and they can think clearly, give the management to them, because they are cleverer than some of the people, without knowledge they're managing. So you have to, because some of the people are so empowered, my type 1s can speak more knowledge than some of our new doctors, or, people, even consultants, some of them who don't know about diabetes. They could be a cardiologist, but my patients with type 1, because they've had so much education, they are quite empowered. So it depends, you gauge your patient and don't take away the control completely. That's one message I would like to give. And I think Gladys has already talked about it. As nurses, it's important to look at the sites. You'll be giving insulin, and then you'd find, oh, why is it not working? So always, look, whether they have lumpy, bumpy areas. We call that as lipohypertrophy. You ask them, if even as a nurse in any specialist field, ask them to rotate the site. These are just simple, messages not to kind of miss. This is exactly what I meant by lipohypertrophy. Injecting into the same place much of the time can cause hard lumps or extra fat deficits to develop. And that's quite unsightly. Some patients are quite disturbed, but the main thing as educators is, asking them to rotate. Yeah. And now we end up with all the funny gadgets. This is probably a talk for another day, but you get pumps, isn't it? And the first question all the patients ask is, why can't I have pump? But pump is not for everybody. It's for people with type 1, unfortunately, in UK. If you were in US where you self-fund, then some of the type 2s have it. But the thing is, it delivers insulin, every hour. You can program the pump in many different ways. There's many fancy pumps available, but still, we do need a sensor. Yeah. So there is, you talk about artificial pancreas. We are almost there. There are some very posh pumps, this Medtronic company has produced. They, have sensors and they talk to each other, but still it is not fully independent. Still the patient needs to input data. Yeah. And still, you cannot give the control fully to the pump. It's not yet fully perfect. Yeah. So I'm sure in our generation, we will find that. But people with type 2, whatever said and done, this is not going to be the cure until, we cut down our intake and exercise. Going back to the basics is the key. And for nurses, again, be careful. I will go to the main slide. So 6 steps: the right person. Are you giving the right insulin? Are you using the right device, the right dose, the right way to do it, and at the right time? Say if the patient has had breakfast, say 8 o'clock, and you go at 11 o'clock, don't go and inject that 30 units. Always question that. You can always ask your doctor, question the doctor. Sorry, we didn't inject at the time. He's had an, meal early. Can you reduce the dose, or what is the best way to do it? You can measure glucose and then, act accordingly. Some patients who are unwell, who haven't eaten, probably will not need the dose. So kind of challenge your doctors, because your junior doctors don't have the information. So be careful, because that can lead to, ups and downs in the control. Yeah. So this is for people who are nurse prescribers: correct dose, frequency, a good, pen, clear handwriting. For those of you who are blessed to have electronic prescription is good, but our place, I think I've been here for 7 years and they've been telling it's coming and coming and it's never come. The strength of insulin is important. And if your doctor hasn't clearly prescribed, challenge them to re-prescribe. Units should be written very clearly. Yeah. And this is for people, especially, I would like to point out, this is a very good website for type 1. Diabetes UK has a lot of information about type 2, but this is, you just have to go Google and put type 1 diabetes resources, and this website comes up. And, there's so much information, sick day rules, patient blogs, and it is a wonderful website. It's been designed for people with diabetes, with experts, patients. So that's good, information. And, these are just pictures of different gadgets. Again, before you go, we can speak about them in another meeting. I know we are running out of time. And I think we can do the cases another time. We can go to some question and answers. So basically, I would like to go to my last slide. Yeah. So diabetes is not for us 1 or 2 diabetologists, or 1 or 2 diabetes nurses. I think it's for all of us to join in, to team. That's what I call it. You see all hands together. So together, everyone achieves more. There are no dreams, no large, no innovation unimaginable, and no frontiers beyond our reach. So, we should always try and help others, even if there's no money. Just spreading that knowledge around, even COVID or no COVID, you are the answer to many people's prayers. And I just wish that, this pandemic settles. And thank you so much for this opportunity.
Thank you so much, Dr. Mahendra. It was a fantastic presentation, and you went through so much information. And I'm just going to ask this of you now before I forget. Is there any way that you could share your slides with us? Because I know that a lot of our healthcare professionals would like to take time to sit down and sort of ingest what you've been speaking about. Is that okay?
Absolutely fine. Yeah.
Fantastic. Thank you. So we do have quite a plethora of questions, which means, Gladys, maybe we may not be able to do your videos. So just hold on to it for a little bit for us. Wow. I think I'm going to start with one of the last questions that actually came up, because we're talking about management of diabetes within the hospital setting, and somebody has a question around frailty and insulin control in hospitals. So they say that some places some places drive CBG between 4 to 7 millimoles for the elderly, although they may have their own usual drugs. Now, I am not a diabetic specialist. I have no idea what the CBG means. Charity, do you know who asked this question? Charity, I can't hear you.
Oh, yeah. So CPG, Dr. Mohandas and Gladys will know, because we use different terminologies, isn't it? Blood glucose. Yeah, that's what we like to use these days.
Okay.
Yeah.
Right. So
unfortunately, my computer has died, but we've come together for the right. Sorry. Anyway, so what was the question? You want to answer that?
Yeah. I mean, we wouldn't tend to drive our elderly patients, whether they're in hospital or in the community, to that level of tight control between 4 and 7. I mean, often we'll say we're happy if they're sitting between 6 and 12, or even 7 and 12. And again, it's individual if they've got other comorbidities. So if they've got a heart attack risk, a big heart attack, couldn't push them at that level. And if there's a lot of hypos, again, your patient's more prone to having things like heart attack, so that whole way up.
Okay. I think I'm just going to reiterate what Dr. Mohandas stated earlier, that if you're a healthcare professional, make sure that you are questioning, you're challenging. If you see things are out of, that don't look normal, and try to individualize your point of care for your patients. So we'll take that moving forward. There was a couple of questions around symptoms of what could be diabetes. So somebody is asking if there's a relationship between migraines and diabetes. Another person asked a question around tingling of feet in the middle of the night, specifically at night. Could that be probably diabetes?
You want to go ahead? No. Okay, fine. So all tingling of feet is not diabetes. However, it is important to get, blood glucose checked, because I do know that I don't want to you to take away, every symptom could be related, but say it could be, say nerve damage, because small nerves, if it's damaged, you could get that, tingling sensation. However, there's multitude of other problems. First is even, if you're simply tired, or if you're anemic, or if you have calcium problem, so those of you who are vitamin D deficient and have calcium problems and other, conditions. So even with COVID, as you know, post-COVID, many people have nerve damage. So, you could have a lot of other conditions as well, which can cause this tiny tingling, but it is no harm in getting your blood glucose checked. Yeah, Gladys clearly pointed out the main symptoms, isn't it? Yeah, thirsty. Of course, because you're thirsty, you're going to the loo all the time, and then hungry all the time, and if you're losing weight, and then infections. But if you have a very strong family history, and if you're slightly worried that some of these subtle things are happening, please, ask your GP to check for your glucose.
Okay, I'm just going to catch on to the last phrase that you talked about, if you've got a family history of diabetes. Somebody asked if there is a genetic specific diabetes, where some people just get diabetes regardless of lifestyle or intervention. And I have been recently reading about MODY, the maturity onset diabetes on the young, where they're saying that, it doesn't matter. It's just genetic. If your parent or somebody in your family has got it, you could likely get it, and that 1 in 13 South Asian and African Caribbean people diagnosed under 30 with type 2 diabetes may actually have MODY.
Correct, exactly. So, you would find that, Peter, what is that place? Exeter. So Exeter, they do a lot of testing for MODY because, they have funding to do it. And you would find, because they are testing a lot, they find MODY a lot. It doesn't mean other areas don't have it. We also check the appropriate people, because some of the time, the treatment doesn't, change a lot, except in few conditions of MODY, people who are on insulin, can be off insulin. So that is life changing. So nowadays, days we have started to test more because these funding facilities are available. But what I want to kind of to take away the message is all of us who are Blacks or Asians, my my GP beautifully puts it. She when she speaks to me, because of course I am in her GP practice, she says it's not whether you will get diabetes or not, it's when you're going to get, because our lifestyle and what we eat, and genetically we're all programmed. Even now the whole world is kind of going towards type 2, isn't it? So because of our lifestyle. So I would say, of course, there are of course genetically there are few rarer forms, but the big message is that all of us are genetically programmed to get it. So how we can stay fit and have a healthy eating to get not to get that. And even if you have MODY and other types, of course there's treatment, but there's sometimes we find, although we treat the sugars well, there's other complications in them, like heart, their feet, the stroke, because what's happening is we are not looking after our well-being. So that's the main message I want you to take away.
Okay, I think there's a whole topic around what are called the new type of diabetes out there. I know there's diabetes 1.5, LADA, the latent autoimmune diabetes in adults, and MODY. I think maybe we need a session to just look at those in the entirety, because it's new information and people want to hear about it. So I'm just going to put that on the back burner. Charity, I hope you're taking a note. We're getting both of these lovely presenters back. Right. So I'm gonna,
because we are speaking amongst Black population, Malawi, which part of Africa is that? North is in
Southeast Africa.
Southeast, yeah. So we do know that in Western Africa, especially Nigeria and Ghana, isn't it? Mainly, we find ketosis prone type 2. So although you have type 2 diabetes, you behave like type 1, which is double whammy, because you're big, of course, have insulin resistance, not the slim person, but what happens is your pancreas, which the organs which secretes insulin, goes into a heart attack, like a pancreatic attack, where it just completely stops secreting insulin. Then when you kind of live a good life and then maintain a good diet and exercise, then those people rapidly, then the pancreas recovers like magic, and then you can come off insulin. But not all, but there's a condition which I'm sure people are interested, flatbush or flatbush diabetes, and it's called ketosis prone type 2 diabetes in the scientific term.
Fantastic. Gosh, we're learning new terms as we go along. All right, I'm going to go and just run through the questions that were put up on the chat. Can you please clarify on fructosamine test, which is an alternative test of the HbA1c for those with sickle cell anemia, and I think the sickle cell trait?
Yeah. The ideal test is obviously, HbA1c, and some of the labs now have overcome, those assay differences. But there is an assay called the fructosamine assay. So there's a range we have. So the lab itself will tell you, you cannot, trust this HbA1c. There's something interfering. Not all labs, if you work in big labs, some of them have overcome all these differences. But when they tell you, this patient has got a variant, or, our assays cannot measure, it depends on the assays they use, then we use fructosamine assay, but that is not required in a lot of majority now, because, they are getting better and better assays, to measure your glucose to overcome.
Okay, so when we've taken the HbA1c as a test, and let's say it's below 53 millimolars, somebody's asking, would you stop anti-hyperglycemic at all?
I wouldn't. So, so even if you're 48, say if you're someone who's done a lot of lifestyle, we do see patients who have lost 20 kilograms, really hardcore lifestyle, they've lost it all, or bariatric surgery. That's a topic for another day. So, you've lost a massive amount. In that case, of course, in that case, we will, we know that your diabetes is in remission. So if your HbA1c goes to like 42 millimole or like 5.5, you know, in the non-diabetic range, we might stop it. But even in most of the patients, say if you're Black or, you know, BAMI population, we try and keep them on a tiny trickle of metformin, because you never know when the relapse is going to come. And in US, they give metformin. In UK, it is not. They give metformin even in pre-diabetes, because what they know is it you know, prevents the delays the start of your diabetes. So that is what it is. You know, sometimes you might find, oh, I'm free of medication, which you have to be careful if you are able to kind of be in that state. And also you have to monitor. Monitoring is the key.
Okay, so I think the next two questions are still around the stopping of medication. So I'm going to ask them together. First one is, when do you stop insulin in type 2 diabetes, and what alternatives are out there? And when would you say diabetes is in remission and stop treatment that a patient is on?
Okay, so do you want to answer? Okay, fine. So, you know, with type 2 insulin, okay. So, you know, say today, I will give you an example. I saw a patient who was on insulin. He's an elderly gentleman. His HbA1c is 6.5, you know, really in ideal range. And if you look at so it's not depending on just one. You know, if you look at the range over the last few months, it's always been around, say, you know, 48 to 50 in the new terms, or 6.5 to 7%, you know. So it's always in that range. And I was just wondering, why did the GP put this person on insulin? So I question, is it definitely type 2, or if they have, you know, if their pancreas is run out? So it has to be decided by a doctor and not by a patient. So if you know that this patient was started on insulin for a short period, the kidney tests are also normal, because sometimes people are on insulin for a particular reason, type 2s as well, because if they are EGFR, you know, the way the kidney function works is less, then we cannot give most of the medication. We can give 1 or 2. So in that case, they are on insulin. So before stopping, we will tell them, you know, it's a case by case basis, not just one aspect. So it is, I don't want anybody to go with the message to their GP, stop my insulin, because there are people doing out there just stopping and putting them on tablets. And then we see Gladys has to be seeing patients urgently, because then they just rock it. So it's always careful stopping of insulin. And of course, there are alternates. Now, as I said, the new drugs, you know, which helps you lose weight, but not everybody will respond to it either. And not everybody will tolerate. Say today I stop, like Gladys says, okay, let's stop insulin and give you this injection. Of course, you know, patients want to lose weight, but then they give her a call 2 days later and say, oh, I can't take this medication anymore, cannot tolerate the side effects. And then what happens? You don't want to come with sugar. So whatever drug change or stopping, it has to be done with careful monitoring, weighing the patient's, you know, individual, but you know, on a case by case basis.
Fantastic. I'm still going to stick onto the HbA1c, because it seems like people quite like that topic. The question is it true that HbA1c is not reliable in renal patients or those on dialysis? And why not? Either way?
Yeah, so that is correct. Yeah, because, you know, the people are anemic. Yeah. So when you're very, very anemic, you know, and also they give injection, you probably know erythropoietin injection, you know, to make red blood cells. Gladys rightly pointed out that sugar sticks to the red blood cells. Yeah. I wish, you know, there used to be like somewhere where there's red blood cells are like the tiny donuts. Yeah, and then sugars, you know, our sugars stick to it. So what happens in kidney disease is that, you know, that red blood cell count just decreases, you know. So just imagine if you have a cup of those donuts, and then instead of 10 donuts, there are only 1 or 2. So, you know, but the sugars will still be there. So, but it is not accurate because you don't have enough red blood cells, and then sugars hanging around. So it is not accurate because of the way it is. And also with the kidney dialysis, the machine, you know, turns over blood glucose, isn't it? Yeah. In those people, the reliable thing is your finger prick. And some of them now, you know, can get this flash monitoring, which we will speak on another occasion. Yeah.
Okay. Thank you for that. I think the next question is regarding diagnosis of type 1 diabetes. And the question is, why are we seeing the elderly more being diagnosed with type 1 diabetes?
I would say possibly because we're actually able to test more. We test more for antibodies more, whereas previously that patient would have probably been presumed to be a type 2 patient just because of their age. Whereas now we can actually test for antibodies more. We can check patients' ketones on a blood ketone test as well, which again indicates are they more a type 1 or type 2. So some of it is testing, and some is just the fact that the more we're able to test, the more we're able to see and actually realize that it's not just the youngsters that get type 1. Some of our patients can be up into their 90s on their first diagnosis. So it's more knowledge, more able to test, and just keeping an open mind sometimes.
Okay. Whilst I still have you talking, Gladys, there was a question specifically for you. So how do you decide on insulin dosage on an individual?
You can do it, if you want to be technical, you can do it on weight. Again, sometimes if it's somebody's come in and they're newly diagnosed, I may look at how much insulin they've actually required initially. So again, a mixture of things. So it might be sort of a best guess, as in I'll put them maybe on 0.2 units per kilogram as their background. So it really depends on the situation. But often if they're in hospital, I'll have that extra information as to how much insulin they've actually required intravenously as well. And I'll be guided by that and their lifestyle and other factors as well. And sometimes I'll give them less than I think they need so that they can build up the dose.
Correct.
Okay,
But
fantastic. All right.
Hypos.
Fantastic. So I've got a question from Dr. Nyasulu, I think based in Malawi. I think putting it into context in Malawi, we tend to get a lot of patients coming in with hyperglycemia. And traditionally, for example, I think a lot of us would have had a relative or two who would have just died out of nowhere because of hyperglycemia, not realizing it's hyperglycemia. I had an aunt who went to a party from the village. She's never been to a party. She went to a party, came home and died. We didn't realize that she had eaten so much cake and all that sugars had put her into hypoglycemia. So what Dr. Julia is saying is that the challenge that she has observed in Malawi is managing hypoglycemia in hospitalized patients. What are the key messages or principles to apply to control high sugar?
Want to talk first? Yeah.
I mean, probably a lot of it is education and awareness around what actually affects blood sugars. So, I mean, dietary aspects, if you're thinking about type 2, it's dietary aspects, a massive thing. And a lot of the time patients just think of, in relation to their blood sugars, they think of the sugar that they're eating. They're not thinking of the rice or the pasta or the potatoes and the fact that they all break down to sugars. So I'd say a lot of it is education. And obviously being able to monitor your own blood glucose levels, I think is a big thing. Because again, it's fine going to see a doctor and they say, oh, your glucose control is not good. But actually, how does that affect you day to day? And what can you do about it day to day? So being able to monitor is probably a big thing. And appreciating those signs and symptoms.
And one more thing for the doctor, you know, if she wants protocols, UK protocols, all she needs to do is Google and do JBDS, Joint British Diabetes Society, JBDS, yeah? Yeah, Joint British Diabetes Society. If she Googles, then you can put in DKA guideline or HHS. So high HH, you know, this is again a topic for another day because we can go to emergency.
And there's in hospital and there's community management. There's lots of different guidelines in there.
Yeah, it's very good. Or she can just go to the Diabetes UK and they have so much free resources for the professionals, you know, so she can see, although, you know, like say in India, they don't manage like UK, but if she wants UK protocol to see how we give insulin, what fluids to give, so that, you know, I know it's too much for the other audience, but she can go into the protocols and I'm happy to send over some to you, Chamundi, isn't it? Yeah.
Yes, please. That will be really helpful. Yeah, and I think I'm still sticking with Dr. Juliet's question, and this is around what she had observed with individuals during COVID. So for example, when an individual, for example, developed high blood sugar when they had COVID, and then it resolved 2 weeks later after recovery from COVID, what advice would you give regarding the long-term effects of this? So I know that in the UK, we're beginning to see a lot more cases of post-COVID diabetes that's beginning to creep up. And I know in Malawi, we've also had our own spike with COVID, and it's something they're beginning to pick up. So what advice would you give?
So it's the same advice we give, Gladys was talking about, for any new diabetes, the symptoms we spoke, it is the same. To look for the symptoms, like when Gladys talked about pregnancy, it's the same, when some of the women have, diabetes during pregnancy, but for a period, it goes away when the baby delivers, but it can come anytime. So it's just a basic advice, to look for the symptoms. And if they are feeling unwell, to have their sugars, checked. Mm-hmm. Their doctor, because the same thing, thirst, look for thirst, weight loss, or feeling unwell, even other, because with COVID nobody knows how this is all going to go in the long term. But if you feel unwell, tired, being all the time, and then you're not yourself, then just have your finger prick or blood sugar checked. I'm not sure, the availability of medical. So how is the the community system there? Do they have to go to hospital, or do they have little doctors like India?
Not a lot.
Well, can I have somebody from Malawi in the healthcare sector answer that question? I know we've got a couple of people, a couple of nurses, a couple of public health professionals in the audience.
That is important, like whoever is in that, so that you can direct patients to the first level of people, because I'm sure the doctors in hospital are managing a lot more emergency, but your first port of call who test sugars when these people
in the community
come to them.
We've got Omba on the line. Omba, you want to unmute and maybe give us some insight in terms of your primary prevention in Malawi.
Hello, Omba, we can't hear you if you are speaking. No. Okay. I hope they can come out. Or if anybody brave enough to comment that, please unmute yourself or put your hand up. Another question. So I think back home, we have a huge issue where people don't realize they're alcoholic. Alcohol is part of our lifestyle. Yes. The question that comes out is, how does alcoholism actually contribute to the diabetes health problem?
Yeah, I mean, with, I suppose, increased alcohol, you've got the risk of pancreatitis. So again, damage to the pancreas, and that, I mean, it can affect obviously insulin production, but it can also affect how the gut hormones and how you actually break down the food in your gut. So that in itself can have a big impact, and pancreatitis can be one of the causes of diabetes as well. The other thing as well is, depending what alcohol patients are drinking. So if they're drinking things like lager, cider, I mean, maybe not cider over in Malawi, but if they're drinking those type of drinks, they're high in sugar. They've got carbohydrates, whereas your spirits don't have carbohydrates. All the alcohol is actually converted, all the sugars converted to alcohol, so they don't have a big impact on blood sugars per se, but it's the effect of alcohol in the pancreas that can damage the pancreas that can then lead to diabetes.
Yeah, and one more message is, as Gladys said, is you have to be very, very careful with alcohol, because what can happen is alcohol also can put your triglycerides, which is your very bad cholesterol, up, and your blood, we have seen, is sometimes milky, with pancreatitis. So it not only affects, just the diabetes, but, your whole, it can cause heart attack, pancreatitis, stroke, when all your blood contains fat. So that is one thing I tell people is, do not kind of overdrink. Of course, you can have a drink, but with, COVID and, sedentary lifestyle, and alcohol is just not going to be great. But however, you can drink within moderation. But that is, different for different people, I know.
Well, your moderation, my moderation might be different.
How much is it in UK? You could tell them the units.
Yeah, I mean, you were looking at 14 units for ladies, but they dropped that as well, didn't they?
Yeah, they're dropping it. It might just tell us nothing at the end of the day. So I think one of the things that back home that people tend to see as part of being affluent in society is if you're nice and round in the middle, in the gut area, it means that, well, life is good, isn't it? And you know, there's certain things that we take for granted. For example, that a woman should be a little bit heavier. That means that she's a proper woman. I mean, I'm one of 10 children, and my brothers wouldn't want to touch a slim lady because it means that, oh my gosh, she's too slim, but she should have a little bit of meat in certain places. So there's a lot of cultural issues that we have to take into consideration in lifestyle as well, with regards to how we cook our food. Once you are beginning to be a bit more affluent, you're eating a lot more red and brown plates. If your plate looks very green, that means you're going back to the village. I'm trying to go back to my mother's village diet. So, I mean, I know you've spoken about this quite a lot, and I wanted to re-emphasize this for my audience once again about lifestyle changes, about, diet, exercise, food.
Research, if I can pass to people, because, you know, this is like very well studied, you know, several research in Black communities that, you know, women, you know, the figure we are talking about, the pear-shaped or, you know, nice voluptuous curves. So the diabetes is mainly because weight driven. So if women are slimmer, then you can be cured of diabetes. Whereas in men, it is not the case. So that is why, you know, we had to study in London why men, African men, although they are slimmer compared to their white counterparts, they still have raging diabetes, sadly. Whereas it's very easy for women, if they lose that curves and become slightly slimmer, you know, your diabetes gets better. You can be in remission. So that is a challenge, actually. And I know in our culture, it is like that. You know, even in India, it's the same. You know, the beautiful actresses are the ones who are a bit curvier than the stick thin ones. But now, you know, it's all changing. And now, as you know, people are a bit more health conscious. And of course, you can deposit fat in some areas if you are kind of low risk. But, you know, if you're high risk, you have a family history, and then you already have all these risk factors. If you're smoking, drinking a lot, then obviously you have to be very careful. And I think you can be sometimes, you know, slightly bigger. It's no harm as far as, you know, you're burning those calories and you're fit, because some of them are, you know, not stick thin, because that's how, you know, familially they are programmed, genetically they are programmed. That's how, you know, the bodies are programmed. But whatever you are, just eat healthy and exercise.
Fantastic. Thank you so much for that. I've got a comment in the chat from Malonjo. He just, they say that preventative programs in Malawi actually include health talks on TV and radio. They've increased in physical activity throughout use of gym and more eating healthy in terms of reducing sugar and so on. And they also talk about intermittent fasting. Oh, yes. It's a new phrase that's coming up. I know that the younger generations now, I've seen like on Facebook, on WhatsApp, they go out and do long walks and hikes in the nice scenic areas. So people are becoming a bit more conscious and aware of their health, which is a good thing.
Very good.
So I'm very conscious of time. Yeah, I'm very, very conscious of time. I'm trying to make sure that we do sort of finish on time, but I want to give both you, Dr. Mohandas, and Gladys a last chance to just wrap up in about a minute each. What would you want us to take away from today? What are the key messages that you want us to take away? So Gladys, because you are first speaker, I'm going to throw the floor to you. So give us a minute.
I mean, I'd say with regards to diabetes, it's making people aware of the potential symptoms to look out for, because, and again, it's because knowledge is key, and getting people really to that lifestyle message, healthy eating, healthy portion size, keeping active. None of us are designed to sit on our bottoms, and I think where everything is automated and everything else, we are much less active